Thank you, Philip. It's great to be here. It's wonderful to see a burgeoning interest in this set of infections that years ago were just little anomalies hidden away to virtually no one's interest. I was a fellow at Columbia in 1971. A young woman came to the hospital who was overwhelmingly sick. She had infection in her lungs, in her bone marrow, liver, spleen, and it was M. avium. And it turned out she had a very exotic condition where all of her white blood cells or lymphocytes were lost through her intestines by an anomalous condition. So she was effectively a patient with AIDS without the viral infection. She had M. avium. And this is 1971, and the way something captures your interest goes all the way back to Mary Lou, who really inspired my interest in these organisms. I'm going to try and advance these slides without burying myself.
Push the thing on the side, the little thing.
The space bar works.
This is what I'm talking about, I think. What we know, and I have framed this in terms of all of the gaps in our understanding of these infections. You probably appreciate it. What we know is that case numbers appear to be rising. Why is that not a declarative, unequivocal sentence? Because we don't have systematic data recovery. And it's really unfortunate that we don't. We're going to be struggling until we create the national energy and resources so that all of these cases are reported so we can keep track of trends. What we think we know is that the need for treatment is obvious. Well, in some cases. It's very interesting when you confront a patient who comes to you or is on the phone or sending an email and says, I have mycobacterium, whatever, in my sputum. Do I need to be treated? And the answer is, don't know. We think we know that multi-drug therapy is preferred to monotherapy. By that, I mean instead of just taking one antibiotic, you take typically 3 or more. Then we really inherited that from tuberculosis. I mean, the model of tuberculosis was early on that a single drug was not adequate because the bugs are clever, they'll mutate and become resistant, so we give multiple drugs and hopefully prevent the escape of resistant organisms. Therapy must be extended over months and years. We don't know. Patients will look at you in great earnest concern, how long am I going to have to take these medications? And the response is about like a politician tap dancing around some answer. And the answer is, we don't exactly know. We approximate, and we usually tell the patient that if you do your duty, take all the medicines reliably, and I'm guessing that almost all of you are the kind of patients who do take all of their pills reliably, unlike the males in the audience who are infamous for, well, I really don't need them anymore. We don't know how long. And we will also tell you that when you get through and do it all, we probably will have to treat you again. There's a good chance of that, which is not a very satisfactory response. What do we argue about? How are these bugs acquired? And we've gone round and round, and the whole notion of hypothesis generation is you think about what might explain it. So we wondered about the possibility of linking it to our potable domestic water systems. I think that's plausible, but I'm certain that it's not the only way that these infections are acquired, and that we'll learn more. What is the role of in vitro susceptibility testing? What we have done traditionally with tuberculosis, which is, by the way, the model of all this, is that we take the organisms, grow them on culture medium, and expose them to antimicrobials. And depending on whether the antimicrobial can kill the bug in the laboratory, we use or don't use the bug. The drug, I mean. We don't have a good sense of the utility of in vitro susceptibility testing with NTMs. It's kind of humbling to tell you all that. You've been relying on getting reports. I think it's a bit like a compass. Give me a compass and I can probably eventually find Canada. I'll just keep walking, following the needle north. But don't ask me to get to Toronto or Montreal. I'll be in the general vicinity. I think these tests are helpful. They certainly aren't the absolute guidelines we'd like to have. One of the things that we do at National Jewish, again, it is evolved from TB care. When we give an antibiotic, we want to know whether the patient is receiving an adequate amount. And we do that by giving the drug either IV or orally, and then drawing blood from the patient and seeing whether the amount that appears in the blood is sufficient, presumably, to kill the organism. We think it's logical, but it's not proven to the satisfaction of real scholars. What predisposes one to NTM infection? I would guess that if all of you say, I just want one question answered, it's why me? Why have I acquired this infection? And it is, as you know, largely individuals in this room who've led blameless lives. No good deeds go unpunished. Some have smoked a bit. They're not typically like the males who have advanced COPD, emphysema, in whom the vulnerability to these infections is logical. And finally, is there a role for surgery? I moved to National Jewish in 1982, and I was really primarily interested in tuberculosis. And that was when drug-resistant tuberculosis was really exploding, and National Jewish historically had done that. Why had we done that? Because we'd done tuberculosis, and we had wonderful programs for laboratory support, and as drug-resistant TB cases came along, nobody else wanted them. A drug-resistant tuberculosis case in Philadelphia can cost 100 times as much as a plain case of TB to treat. So if you have a finite burden and your responsibility is controlling tuberculosis in Montgomery County or wherever, and you have a couple of drug-resistant cases, number one, the cases are very hard to treat. The drugs are not easily given. But National Jewish, because we had a philanthropic base, could say, send us your sick, your poor, your weary, your drug-resistant TB. And so that was our reason for being. And by parallel to NTM infections, which are inherently drug-resistant, we began seeing these patients. And we began looking at surgery for tuberculosis because I want you to appreciate that a patient who has active tuberculosis that's not controlled. Hello, Greg Tino. How are you? I'm sorry I missed you earlier. It's one of my dear friends. My eyes are getting bad, Greg. What was I talking about? I was talking about surgery, brain surgery. This is not brain surgery. That a patient who had tuberculosis that was uncontrolled with medication or uncontrollable had nowhere to go. There was virtually, if you had highly drug-resistant tuberculosis in your lungs, you could not return to your community. You couldn't live with your family. You couldn't live in a nursing home. There was nowhere for you to be because you posed a risk of transmission of an untreatable infection. And so we said, if we were unable to control with medication, we'd do surgery. And so we began doing surgery for highly resistant TB, and we saw the analogy for these highly resistant or refractory cases of NTM disease.